Good morning. Straight to business. This 25-year-old female patient has come to you in your clinic with back pain. She's got a history of about 3 months. She's got her constitutional symptoms as well. Now, on her MRI, you can see that there is, on her MRI, you can see a peridiscal abscess, you can see peridiscal destruction. And so, this is clearly a case of spondylodiscitis. Now, with this patient, how do we start the treatment? Should we start her straight away on first-line antitubercular drugs? What drugs should we give her? Should we give her 4 drugs? Should we give her an extra drug or 2? Should I add an extra drug? Should I substitute streptomycin to ethambutol? How long should I give the medication for? And when should I get her MRI repeated? These are the questions that we are trying to answer in my talk, so I'm going to go very specifically on them. Now, a patient like this who is a newly diagnosed case of spinal tuberculosis is put in the category 1 as per the WHO. This also includes all musculoskeletal tuberculosis patients. A category 1 regime basically starts with an intensive phase where you give bactericidal drugs which kill the tuberculi rapidly in the beginning, which includes your isoniazid, rifampicin, pyrazinamide, and ethambutol. Ethambutol can be substituted with streptomycin. And then a continuation phase where you give isoniazid and rifampicin for 4 to 6 months as per the WHO. Now, is this duration of treatment enough 4 to 6 months later on? And this is an important point. Now, there is no clear-cut guideline given as per any protocol. However, studies in literature has given us a lot of evidence and has recommended that the initial intensive phase may be continued into your continuation phase as well. So you may give it for a longer period of time. This, of course, is based on the response to the therapy for these patients. Now, the response to therapy is monitored clinically as well as radiologically. But we know that pyrazinamide, the effect of it acts only for 2 months in the presence of rifampicin. So even a triple drug therapy regime has been recommended in these patients where we give this for a longer period of time. We are rifampicin with ethambutol. Now, the minimum duration of therapy here is mentioned as 6 months. However, a longer duration is recommended in spinal tuberculosis patients. A minimum of 12 months has been recommended by most literature. And especially in the presence where you have not done a surgical debridement or in immunocompromised patients, you need to give it for longer periods of time. And this is all based on your response to therapy. Now, how do we judge the response to therapy? Clinically, we know that patients may get improvement in back pain, they will get improvement in their constitutional symptoms. But an MRI is a very objective method to see how the patient is improving. Now, when do you do an MRI? Do we do it at 1 month? Do we do it at 2 months, 3 months? In fact, if you do it so early, you may actually see an exacerbation of disease if you do an MRI so early. So ideally, it is supposed to be repeated after 6 months of therapy, where you will see this is your MRI done earlier, and this is after 6 months of therapy, a reduction in your in your abscess. You can see improvement in the abscess and in your edema and T2 weighted images, and in T1 weighted images also you see fatty replacement of the marrow. These are all your signs to show how the treatment has affected and how the patient has improved. Now, many surgeons like to give streptomycin. The injection will work better than the drug. So is it advisable to give streptomycin instead of ethambutol? The answer is no. Streptomycin, there is global as well as in India, more than 30% resistance has been seen to streptomycin. So it is not the first drug of choice, and it is only to be given if your biopsy and sensitivity reports prove that it is sensitive to streptomycin. Now, it's very easy to give these fixed dose drugs, brands which are available in the market, just give that to everybody. But is that advisable? Is that the ideal method of treatment? Again, the answer is no. All drugs have to be given based on their body weight adjusted dose. This is to prevent resistance, and we all know our doses based on the body weight. A lot of people like to add a ciprofloxacin or an ofloxacin or a kanamycin initially to the treatment. Will that help to make the patients better faster? Will that make me a better doctor? The answer is no again. These quinolones, aminoglycosides have never to be added to your first line therapy because these are a very important weapon in treatment of MDR tuberculosis in second line. So if you use them early, they develop resistance, then you are going to lose a very important weapon and it will be very difficult to treat these patients. Finally, improving compliance is one of the very, very important points here. We need to explain to the patients from the beginning that multiple drugs may be needed in these, and so they should not discontinue it once they start feeling better. Common side effects like orange discoloration of urine, nausea, vomiting, gas, and even itching is to be expected, and it's not a big deal. The itching, for example, is usually self-limiting and you don't need to worry about it. However, jaundice, hepatitis are more serious side effects and they need to be taken seriously when that happens. So in conclusion, the treatment duration has to be individualized to every patient and you need to monitor their clinico-radiological response to the therapy and give it accordingly. Thank you.